Menopause and Sexuality by Ann Olson, Jenny Olson, and Suzanne Chatters.
Yes, I am.
As midwives, we've all experienced patients that have come into the clinic stating that they're there, for example, a skin assessment, which this patient is, and then you sit down and you start interviewing her and just talking with her about why she's here, and you come to find out that she's here for something totally different other than having her moles checked. Please listen to the case study below as an example of this.
So first of all, I'm just going to ask you a couple questions about your relationship. Are you married or single?
I've been married for 20-some years.
Okay. Male, female?
My husband.
Okay. How is your relationship?
I mean, I'd say we have a pretty healthy relationship overall. We've stayed together this long.
Wonderful.
Mm-hmm.
And how comfortable do you feel about talking to your husband about this vaginal drug medicine?
I can talk to him about it. I mean, he's aware of it. It's been bugging me for about a year.
Okay. And do you feel that it's affecting your relationship with him?
Yeah, I mean, we used to have sex more often, and we'd really like to now because our kids aren't in the house and it's all ours again,
Mhm.
and I don't have to worry about having babies. But yeah, I mean, it's hard to be intimate.
Okay. Does your husband have any medical problems?
No, he's pretty healthy.
Okay, and no sexual problems, erectile dysfunction?
Nope.
Okay, and is he on any medications such as like Viagra or anything?
Nope.
Okay. How about, are you currently safe in your relationship? No abuse?
Mm-hmm.
Okay. Any major stress in either of your lives?
No, we're kind of in a phase where it seems like it'd be nice to be able to enjoy our time together differently than we've been able to this year.
Okay. How about your period? When was your last period?
2 years ago.
Okay. And how has your sex been before your last period and
It was
now?
fairly normal for like the first year post-menopause. I didn't have any hormone therapy, but this last year it's just gotten a lot more painful.
Okay. Any vaginal creams, lubricants?
Yeah, we tried some lubricants, and I have tried that Permanent. It's really expensive and it's kind of messy.
Yeah. Okay.
And it's okay. I mean, it helps. But
Okay. How frequent are you having intercourse?
we've probably tried like monthly because it's just.
Okay. And then how is your overall health?
I'm pretty healthy.
Okay. When was your last physical?
Last year.
Okay. So are you due for one now?
Yeah, I guess I am.
Okay. So how about we'll start with there and then come up with kind of a plan of action, ideas that will.
Yeah, if you have any ideas, I really appreciate
Yeah.
trying something else.
Okay. Sounds great.
Thanks.
We'll get started.
Okay.
Etiology. Menopause means the permanent physiological or natural cessation of menstrual cycles for 12 months. Greek meno means month, and pauses, a pause, a cessation. Menopause is one of the changes that women experience in middle age. The median age is around 51.4 years. It is a reflection of complete or near complete ovarian follicular depletion with resulting hypoestrogenemia and high FSH concentrations. Prevalence. It is estimated in the year 2030 that the total number of postmenopausal women will be approximately 1,200 million. And in 2030, the proportion of those living in the developing world will increase to 76%. Comorbidities of menopause include bone loss, cardiovascular disease, degenerative arthritis, body composition changes, skin changes, balance issues, sexual dysfunction, depression, osteoporosis, dementia, sleep disturbances, and each woman experiences them differently. Some none, and some experience a magnitude of them. Sexuality is individual. Menopause presents in a unique fashion for every woman and is heavily influenced by her culture, her socioeconomic class, education, personal relationships, as well as mental and physical health. Different experiences of menopause are linked to social class and to the degree of male domination. A given level of independence and emancipation allows women an identity beyond their reproductive function and a status unimpaired by menopause. Sex, the capacity for sexual pleasure and the capacity for reproduction are two distinct features. Contrary to popular belief, libido and sex drive do not decrease for all women simply because reproduction has ceased. The principal predictors of a satisfying sexual life include physical, psychological well-being, and the quality of the relationship. Androgens. In women, androgens are produced by the ovaries, kidneys, and the adrenal glands. Levels in women are 10% of those in men. Levels affect sexual desire but do not determine the degree of interest. Young premenopausal women with high androgen levels can have sexual concerns, while postmenopausal women with low levels may remain very satisfied. So again, it just varies for each patient, each woman. Estrogen. The natural decrease in estrogen that accompanies menopause is a principal factor impacting mood stability, hot flashes, and vaginal dryness. Sleep deprivation from hot flashes can decrease sexual interest. Vaginal dryness can cause pain with intercourse. This next graph is a graph that just shows you what happens to testosterone levels during puberty and menopause, which is the dark black line, and then what happens with the estrogen levels during puberty and menopause. And then if you start testosterone hormone replacement therapy, which is the dark triangles, or if you start the estrogen hormone replacement therapy, which is the light triangles. Unique factors that affect sexuality in menopause include age of menopause, self-image and self-esteem, social changes. Examples include kids leaving home, aging or ill appearance that you and your husband are taking care of. Perhaps your partner is in a midlife crisis. Other things can include stress and fatigue from life's demands, which can not only affect your desire, arousal, and also orgasms. Um, how was the patient's past level of sexual interest? Are they having the same amount of sex as they were before she went through menopause? Has it increased, decreased, gotten worse, gotten better? Um, Partner's physical health can impact sexual interaction and also the patient's health. Communication between partners regarding desire and change. Um, has the patient and her husband or significant other discussed how they're feeling? Talked about her vaginal dryness and pain. Um, is it impacting his sex? How are they both feeling about this? Um, and then medical problems and medications. Maintaining sexual health. The etiology of sexual dysfunction during and after menopause is complex. Careful evaluation of each woman's physiological, psychological, lifestyle, and relationship issues must be carefully considered to optimize therapy. First step in treatment is to identify the problem. Is she having pain? Diminished sex drive? Any incontinence issues? Um, First of all, in starting with pain, I would talk with the patient about some complementary therapies. Examples of this include soy, which contains phytoestrogens or plant estrogen that some studies have found beneficial for maintaining lubrication. Other natural remedies include black cohosh, flax, and red clover. Vaginal moisturizers and lubricants such as uh, Replens or Astroglide. Um, Other things that you could suggest are extended periods of foreplay before they have intercourse. Other things with regarding pain are while the patient is having sex, making sure that there's still play, there's still foreplay, maybe masturbation, or both to help keep the tissue more supple and maintain moisture. Um, Consider changing the focus from intercourse to other mutual satisfying sexual activities that do not involve vaginal penetration. These may include sensual massage, erotica, stroking, masturbation. For management of pain with the use of medications, include estrogen replacement therapy, estrogen cream applied transvaginally, or NSAIDs prior to intercourse. You could maybe try one or two or possibly all of them, depending on the patient's preference and how much pain they are having. Treatment modalities for diminished sex drive. Complementary therapies include reviewing the patient's medications list with her. Is she on certain medications that may interfere with her desires, such as SSRIs? Can they be changed or eliminated? Also, just assessing the possibility that maybe the patient has some depression, which could decrease her desire to have sex. Maybe she needs to be put on an antidepressant. Um, Other options would be with or without her partner, psychotherapy with a trained sex therapist, um, which helps the patient manage sexual problems and provides other strategies for maintaining sexuality. Medications used to treat diminished sex drive. Um, really, women are pretty limited on this. There's no magic pink pill yet for women to improve issues of desire, even though there is a magical blue pill for men. Testosterone replacement therapy of pill, cream, patch, or injectable forms is one option. There's also new research suggesting that women produce intracellular sex hormones postmenopausal, and treating women with injectable bioidentical testosterone pellets improves women's testosterone deficiency syndrome, um, which the graph in the earlier slides was taken from this research. So it just maybe would be something that you'd want to go back and look at regarding the testosterone levels and the estrogen levels. And the website for this research is also in the references if you wanted to look up more information on it. Um, Incontinence in sexuality. Complementary therapies that can help women with this include regular Kegel exercises, asking women if they do them or know what they are, and educating them on how to do them. And then just, talking with them about throughout their day, like if they're standing in the line in the grocery store or driving in the car to pick up her grandkids, it'd be a perfect time during the day to get those Kegel exercises in. Others to help with incontinence include biofeedback, bladder retraining. Medications used to treat incontinence. Um, these medications are urinary tract antispasmodics, which work to increase bladder capacity as well as decrease the urge, frequency, and associated with overactive bladder. And the list of these medications is on the slide. Um, And these are recommendations for us as midwives, just supporting our patients' interest in remaining sexually active, talking with our patients at their annual exams about their sex life. Are they having sex? Are they happy with their sex life? Just making feel them comfortable and safe to come and talk to us about sexuality is really important. Educating our patients that um, is an important aspect of physical and emotional health, and it impacts our quality of life. And identifying specialty clinics who are familiar with sexual function throughout peri and postmenopausal, and referring them to these clinics, such as mental health, gynecology, internal medicine, social work. And then lastly, our references. Thank you.